Well, good morning, everyone. I'm Malene Davis. I'm the President and CEO at Capital Caring here in your nation's capital. Welcome to my service area. I am pleased to represent and introduce to you today the Innovations Group, providing an overview of who we are and what we do, and to describe how we believe that hospice as a model provides the essential foundation from which to build out a more comprehensive model of advanced illness care. So let me introduce to you here the members of the Innovations Group. This is a group of hospice CEOs who are dedicated to excellence in end-of-life care. And they have a track record of providing additional advanced illness services and who are avidly working on a model of advanced illness care to complement the basic core interdisciplinary services that hospice provides under the aegis of the Medicare hospice benefit. And I'd like to especially acknowledge Tom Kasumpas and Christy Whitney, David Ream, and Samira Beckwith, who really are the visionary leaders who worked with me to get this group started. And a special acknowledgement, I think that she's here today, Carolyn Casson, who is the CEO of the National Hospice Work Group, who ignited us. So the Innovations Group members leverage core competencies of their hospice programs to provide additional advanced illness services upstream from the time when patients have end-stage disease or when concurrent therapies that may be beneficial are just not covered by the hospice Medicare benefit. At Capital Caring, we have built a large palliative care consultation service, providing inpatient consultations throughout the greater Washington, D.C. metro area. And we also see people with palliative care needs in 7 outpatient clinics, including 2 that are embedded in a national oncology group. We've recently piloted a telecaring program that has proven its value in anticipating and preventing crises and reducing disruptive transfers of care, and thereby reducing overall cost while meeting great patient and family satisfaction. And something that I've heard a lot here in the last day and a half, we have built 3 years ago a program called In Good Faith. And it ties our program to the congregation and clergy in our service area, helping them to identify people with needs in their congregation. And these are things that can happen anywhere in any community. Along with my colleagues here from many of the healthcare arenas, we are here to assert that the skills, the experience, the expertise of hospice professionals, and the interdisciplinary coordinated care model of hospice, when practiced correctly, provides the foundational elements necessary to build out what we've been calling advanced illness coordinated care. And with this assertion, I think there's 2 critically important caveats. First is that hospice professionals and the programs from which we work must be committed to reducing unwarranted variability in our practices. And we must all be committed to evidence-based approaches to palliative care where they exist, and also be committed to implementing and monitoring meaningful outcome measures and then report these openly. And the second is that hospice programs, as Dan was just saying, cannot sit in isolation, being passive recipients of the patients at various stages of near death. We must engage as part of a system. And in so doing, hospice programs will be prepared for the next iteration of healthcare reform and the eventuality of a comprehensive advanced illness coordinated care as a design benefit. This model depicts the necessary overlapping approaches to care required by people with a diagnosis of a chronic progressive condition, regardless of the care setting. Hospice programs must actively partner, integrate, and coordinate with the full spectrum of healthcare providers and with patients with advanced illness and their families. It's critical to improving care with well-defined, realizable clinical outcomes and a sustainable economic model. Within this basic model, if you could imagine lines of convergence among all those participants to whatever extent they exist within the patient's community, such that the coordination of the services via information sharing becomes the norm. That said, we must truly form a coalition of the willing. Those who are not so much interested in what has been, but what can be. So I would just end by saying, if you're not satisfied with the quality of the hospice program within your community, don't ignore it or criticize it. Influence it. Expect, no, demand world-class hospice care. Make it happen while creating the linkages necessary to make a system that works, and that being emulated for all patients with advanced illness in every community. Thanks.